everyone, this is Dohya Prasuna. Welcome back to my channel. Today we're going to start our clinical case series. Our very first subject is ENT. So we're going to discuss about three main aspects in this ENT case proforma. That is the firstly clinical case taking, and secondly general examination, and also thirdly the whole diagnosis summary along with the case that I will be presenting to you. Anyways, let's get started. But before we begin, I wanted to make it clear that I am a medical student sharing educational insights based on my learning, and please note that this is not a substitute for professional medical advice. These are only my opinions and my experiences. Thank you so much. Now we will learn how to take a proper ENT history according to the standard clinical case proforma. We'll cover only history taking, not examination, and I'll also explain why we have to ask each and every question so you can remember it during the exams while seeing the patients. Okay. Now these are the main contents of the history taking. First comes the demographics of the patient. Next, chief complaints, history of presenting illness, positive and negative history accompanied with past history, personal history, family history, and finally the summary of the total case recording or the case sheet. Starting with the basic information, that is name, age, sex, religion, occupation, address. These aren't just formalities. Age helps to narrow the diagnosis. For example, in children, there is acute otitis media, adenoid hypertrophy, and foreign body presence. And in young adults, there is trauma, noise induced hearing loss, and in older adults, there is presbycusis and malignancy. Occupation is more important because factory workers may have noise induced hearing loss, swimmers develop otitis externa, and miners are exposed to dust, etc. And some people are also infected with garden pollen, which can lead to allergic rhinitis and nasal polyposis. The smoke or air pollution can cause asthma and carcinoma of nasopharynx. And also certain diseases are common in a particular sex, that is in males there is commonly Meniere's disease and carcinomas, while in females during menstruation there is increased deafness can occur, tinnitus may occur, and in pregnancy deafness can occur following the pregnancy. And mainly otosclerosis, goiter, post-cricoid carcinoma are mostly seen in females rather than in males. Now coming to the chief complaints, there are mainly 6 different types of chief complaints we have to ask the patient regarding this. So firstly, there is discharge from the ear or otorrhea, decrease in hearing or deafness, pain in the ear or otalgia, giddiness or vertigo, noise in the ear or tinnitus, or inability to do facial movements or deviation of the mouth, also called as facial palsy or Bell's palsy. We have to note that it is preferable to present only 2 of the above complaints as chief complaints, followed by their ODP, that is onset, duration, progress, and then the details of the rest of the complaints. We have to write every chief complaint in a chronological order and always write them in the patient's own words with duration. Now coming to the history of presenting illness, explain each and every complaint separately. Firstly, we are going to discuss about otorrhea. It's also called as ear discharge. We have to ask the side whether it is unilateral, bilateral. Different diseases affect one or both ears. Then the type of discharge. There are different types of discharge. For example, serous, serrangeous, mucoid, mucopurulent, purulent, watery, and bloody. Mucoid discharge is always from the middle ear, as middle ear lining consists of goblet cells which secrete the mucin, and the purulent non-mucoid discharge is a characteristic of chronic otitis media without the cholesteatoma. And there is watery discharge. It is like clear like water, mostly seen in the CSF otorrhea, and also the confirmatory test for CSF should be done. We can ask the amount of discharge by asking about the earbud test to the patient, whether it is copious, moderate, or scanty, and also we have to ask whether the patient is having continuous episodes or intermittent episodes of discharge. If the patient is having foul smelly discharge, then that is the indication of anaerobic or bacteriocydic kind of organisms present in the ear, and if it's a copious quantity, then it is signifies the reservoir sign. If it is scanty discharge, then it is suspect of chronic otitis suppurative media. Now let's dive into the deafness. Deafness, it is the term commonly used to indicate a change in hearing acuity. The difference between deafness and hearing loss is deafness is the total loss of hearing function, but hearing loss is a partial loss or partial hypoacusis. There are actually three types of hearing loss or deafness, that is conductive hearing loss, sensory neural hearing loss, and mixed hearing loss. Once go and check the differences between conductive and sensory neural hearing losses. It's very important as a question for you. And then we have to state about the degree of hearing loss, whether the patient can hear the whisper, conversation, or doorbell sound, loud sounds only. This estimates the severity. And the onset, that is we have to ask whether it's the sudden or gradual hearing loss. Sudden loss is an emergency, but gradual occurs in a presbycus and chronic ear diseases. And the duration, since when he is suffering from hearing loss, and the progression, whether it's improving or not, whether it's static or progressively worsening, and the nature, which is fluctuating, constant. And fluctuating hearing loss is seen in Meniere's disease. We have to also ask about the associated symptoms, that is pain, discharge, tinnitus, ear fullness, vertigo, and other. Effect on daily life, whether he is having difficulty in talking over the phone, difficulty in hearing the classes, difficulty in watching the TV, and etc. Now let's go into the otalgia. It means the pain in the ear. There are several causes of otalgia. For example, in the external ear, it is due to wax, foreign body otomycosis. In the middle ear, it is due to the acute otitis media, CSOM with intracranial complication, acute mastocytitis, and in the inner ear, it is due to the tinnitus, Meniere's disease, vestibular schwannoma, or noise. The type or characteristic of pain is also very important parameter. For example, in acute otitis media, the pain is acute, deep-seated, violent, or severe. In coalescent mastocytitis, the pain is behind the ear and behind the eye. And acute otitis externa, diffuse pain generally. Severity of pain depends upon the amount of edema. And auditory tube dysfunctions, the pain occurs within some time on lying down. We have to ask the patient, is the pain relieved after the discharge? Often pain decreasing after ear discharge suggests of tympanic membrane perforation, and whether it is associated with upper respiratory tract infections, fever, sore throat, or having cold, and is having referred otalgia or not. The ear shares nerve supply with teeth, tonsils, temporomandibular joint, and pharynx and larynx. So pain may actually originate elsewhere. Coming to vertigo, we have to make the patient understand what is vertigo. So it is defined as illusion or hallucination of a movement. It is the false sensation of the movement. And we also have to ask whether the vertigo is sudden or gradual, the type, whether the head is of the patient is rotating or swaying or tilting, whether it is positional, that is occurring when changing the head positions. It suggests of BPV. And whether he's having gait disturbances, means does the patient fall while walking, or and the progression of the vertigo is also asked, like it's fluctuating or constant. And we have to also ask the associated symptoms, whether the vertigo is associated with symptoms like vomiting, sweating, hearing loss, tinnitus, ear blockage, and other nystagmus imbalance, etc. And also precipitating factors are a must to ask, for example like sneezing, head movement, or changing in the position. Now, tinnitus. Tinnitus is the conscious experience of a sound that originates in an involuntary manner in a person or may appear to him to do. Source of tinnitus may vary. For example, cochlea or cerebral cortex or other neural pathways. The etiology of tinnitus may vary accordingly. Like locally, it can be due to wax, otitis media. Generally, it can be due to hypertension, anemia, renal diseases, and it can be also due to trauma, that is noise-induced hearing loss, ossicular discontinuity, and some drugs like salsate, streptomycin, quinine may cause tinnitus. And neoplasms like acoustic neuroma and glomus jugulaire can cause tinnitus. It can be idiopathic, psychogenic, or miscellaneous, like patal myoclonus and other aneurysms. The triggering factors may also vary accordingly. For example, it can be due to stress, noise, ototoxic drugs, trauma, and pregnancy. And characteristics of tinnitus also can be asked, whether it is dull or continuous, rhythmic, or pounding with a pulse, and fluctuant tinnitus, as it can seen in Meniere's disease in males. Unlike the other symptoms, we can actually see facial palsy on the patient. We have to ask when did the facial weakness begin, whether it is sudden or gradual. We have to ask about the change in facial appearance, whether he is unable to close the eye or not, watering of the eyes, drooling, difficulty in chewing, food collecting inside the mouth, unable to whistle. These are the characteristics we have to observe accordingly. And the eye symptoms such as blurring of the vision, redness, dryness, we have to explain it, because inability to close the eyes can expose the cornea and lead to exposure keratitis or corneal ulcer. And we have to characterize the palsy, whether it is complete or incomplete, whether he is having pain around the ear or not, numbness, recent upper respiratory tract infections, or previous surgeries or trauma also should be known. Now, coming to the positive and negative history, it is very important in Viva actually. Always ask for danger signs. These are the histories we have to ask accordingly in the positive or negative history. These may indicate mastocytitis or intracranial complications. And these conditions may either predispose to ear disease or explain the underlying cause of the patient's symptoms. In history taking, past history is important because it helps to identify the diseases or treatments that may explain the patient's current complaint or influence diagnosis and management. These are the 6 main past history points we have to keep in mind while asking the patient. And also, please make sure to write the medical history and surgical history separately in past history itself. Personal history identifies the lifestyle habits and environmental factors that may contribute to the patient's disease and also helps plan management appropriately. Bowel and bladder habits helps to assess the patient's general health and identify associated systemic diseases. Addictions are important because smoking, alcohol or tobacco chewing strongly associated with oral cancer and oral submucous fibrosis. The socioeconomic status is also a major scale that helps to identify the patient's disease and his conditions according to modified Kuppuswamy scale. The diet is to assess the nutritional status, which means the deficiency may contribute to oral lesions or glossitis. Disturbed sleep may suggest nasal obstruction, snoring or obstructive sleep apnea. Appetite, loss of appetite may indicate chronic infection, malignancy or systemic illnesses. Going ahead, it is the family history. It's important because it helps to identify the hereditary diseases, familial tendencies and communicable diseases that may explain the patient's condition or increase the risk of certain ENT disorders. We can inquire about similar complaints in the family members, hereditary hearing disorders, allergic diseases, tuberculosis, malignancies, consanguinity and any significant medical illnesses in the first degree relatives. And that's all for today's session on ENT case history taking. I hope this video helps you understand the ENT case Proforma in a simple and systemic way. In the next part, we'll cover the clinical examination of the ear in detail. If you found this video helpful, please like, share and subscribe to support the channel. I would like to thank you all guys for watching this video and staying and bearing with me all along. For more interesting updates, like, share and subscribe. Thank you. Bye.